Alamin salatu wassalamu ala ashrafil anbiya wal mursaleen wa ala alihi wa ashabihi ajmain. So now I'm just dealing with the pathology and genetic basis of breast cancer. Yesterday, Dr. Ahmad has taken a very long lecture for you where he has touched about the basic definition of neoplasia. You people know better than me now, and you know the what is the what do you mean by benign tumors? What do you mean by malignant tumors? What do you mean by a word called carcinoma? Okay. What do you mean by sarcoma? Everything they have touched it. So, inshallah, we try to focus our attention on breast cancer and its genetic basis. Carcinoma means epithelial malignancy. Okay, he has taught you yesterday. And sarcoma means mesenchymal malignancy, mesenchymal cancer or mesenchymal malignancy or connective tissue malignancy. Remember, malignancy means cancer. Remember this point. That's so important. Okay. Now I'm just trying to focus my attention on this word called genetic basis of breast cancer and the pathology of breast cancer. It's one of the commonest cancer you find in Saudi Arabia. So I hope that you try to concentrate and go and read today the chapter in Robbins. Buy a big Robbins, 10th edition from Jarir, 10th edition, and try to read the breast cancer from it. If there is any doubts, please do ask me in my WhatsApp. I will try to answer you because we don't have much time to discuss. Now, the genetic basis, what do you mean by the genetic basis of breast cancer or any cancer? It goes with the understanding of you know how the DNA is being derived. So DNA, what do you mean by DNA? You can see over here, it's something like this. It's a chain, spiral chain, like molecules made of nucleotides. Okay, these are the nucleotides basically. You can see over here. You can see over here, and they're rearranged. So what is basically a gene? Suppose there's a stretch of DNA, like a stretch of DNA, and this small part, must learn this. Okay, this part, this is called a gene. Okay, and this particular gene is made up of nucleotides. Okay, and they code for a specific protein. Okay, this the code for a specific protein. So I know that Dr. Ahmed did not teach you the what do you mean by cancer at genetic level. So what is cancer basically by definition at genetic level? It's a genetic disease. It's a genetic disease where the nucleotides become abnormal, okay, and they code for an abnormal protein. And that abnormal protein, instead of stopping the cell proliferation, it'll cause to proliferate abnormally more. A cell is supposed to die, maslan, by apoptosis. Okay, it does not die. The apoptotic mechanisms failed, and the P53 mechanisms failed because of mutations. A change in the nucleotide sequence is called a by a change
Yes,
in
sir.
the nucleotide sequence is called mutation. Yes, anything you want to ask me?
No, thank you.
Okay, so just I'll try to be slow because we have only 1 hour, but I'll repeat the sentences. So this mutation, when there's a change in the nucleotide sequence, this will cause formation of a protein, but other abnormal, more normal, more tabi'i, yani هذا خطير جدا. So this will cause cancer. Has a definition at the genetic level. Okay. Yesterday, Dr. Ahmad has taught you the morphological patterns. I'm teaching you the genetic patterns. Okay. Now, what do you mean by neoplasia? New growth. Has a revision, new growth. Okay. What is cancer? Other name is malignancy. Okay. I told you epithelial cancer is called carcinoma, and connective tissue malignancy is some sarcoma. Okay. Now, mutations cause uncontrolled growth. The growth which is being controlled in our bodies, like you, me, everybody who's not having cancer, is uncontrolled proliferation, uncontrolled growth. So, cancer is a genetic disorder. Okay. Now, new tissue growth is a neoplasia, right? Neoplasia, new growth. This new growth is unregulated, irreversible, lysa polyclonal, has a monoclonal. One, one clone of a cell is being proliferated. Other clones are normal. That one clone will proliferate and become abnormal, and it becomes a mass. Okay, it becomes a mass. So You have to differentiate from hyperplasia and repair. I don't know if people have taught you or not yesterday. Mama hyperplasia, mama repair. I'm not going into details, but I'm more interested what is happening at genetic level when there's unregulated growth. Growth is irreversible, and growth is not polyclonal. It is monoclonal. For all infection, the growth is polyclonal. Remember, okay. Then we go to a cancer is the second leading cause of death. Okay, so the by incidence, Mafar Banal incidence or death rate as the Mohim Jiddan list all exams like SMLE or URS, USMLE or your PLAB or even your Taiba University. By incidence, number one is breast and prostate, which we are studying today. The breast. Number two is lung, and number three is colorectal. But by mortality, lung patients die more as compared to breast and prostate, which is second. But colorectal cancer is third in both incidence and death rate. The Mohim Jiddan, as a slide, Mohim Jiddan, very high yield. Is a can any doubt? Just stop me and ask me. You can ask. No problem. Has a more lecture and more muhadra as a muzakira. Okay. Barakallah. Mutations in two types of genes lead to cancer. Now, this is very important. I'm teaching you mutations. What is mutation? Change in nucleotide sequence. Okay. Now, the tumor suppressor genes will have mutations, and the oncogenes. Basically, this word I don't like it. As a Muslim, the correct word is proto-oncogen. Shufina mawjud. Proto-oncogen. Shufina. Proto-oncogens are essential for normal cell growth. Maktub hina, normal cell growth and normal differentiation. Normal differentiation. Tabi hai. Other yusama proto-oncogens. If the can mutation is in the proto-oncogens, other jadid genes yusama oncogens, these are cancer genes. Cancer genes. They will cause what? They will cause other unregulated growth, irreversible growth, and monoclonal growth. Shufina, as a proto-oncogens will cause normal regulated growth, reversible, or then Bakia is polyclonal, polyclonal. Okay, polyclonal. So mutations form from proto-oncogens, they form oncogenes. So this leads to unregulated, irreversible growth, and apart from that, monoclonal. Okay, cell growth. This is very important. If there is any doubt, I'll just proceed to my next slide because slides are very less, and I think we should be very frank in telling. Okay, now tumor. What I told you, the mutations occur in two types of genes, tumor suppressor genes and proto-oncogenes. Proto-oncogenes. So these proto-oncogenes are physiological. Okay, physiological. And this will become oncogenes, which are cancer genes, and they are all pathological. Okay, causing tumors. Okay, tumors. Tumor can be benign, can be malignant. Benign is Hamida, Saratan Khabisa. Malignant tumors, epithelial cancer, Usama, carcinoma, and connective tissue, Usama, sarcoma. Okay. Now, tumor suppressor genes they limit the cell growth. How the normal? And one of the tumor suppressor gene very famous in the whole world is P53. Another one is called a retinoblastoma gene, and the cell cycle regulators and the nuclear regulators. Mohim Jiddan. Okay, this you got to understand this one. Apart from that, I'll tell you one more thing. Now, I'll take the advantage of this one. I'll draw a cell over here. Okay, this is the cell cycle. Okay. Now, this is a cell, basically a cell which contains cytoplasm, juva, one nucleus, in a nucleus, in a cell membrane. Okay. So this is a growth factor coming from outside. On this is the growth factor receptor. Here there's a tyrosine kinase maslan to some signal transduction molecule. Mohim Jiddan. Okay. If you understand this, you can understand the Robbins. This will send signal to the signal transduction molecule to the nucleus. It will go and affect the nuclear receptors and the cell cycle receptors. Now, if everything is going on fine, these are proto-oncogenes. Growth factor receptors, signal transduction molecules, nuclear receptors, and cell cycle are all proto-oncogenes with which they control it. Now, if this becomes okay, then this cell will be put into cell cycle. Okay, G0, G1, G1, SN, G2 phase. So what will happening when the cell goes normally into the cell cycle? So it will grow, and finally it will cause transcription, making of mRNA. mRNA will code for translation, that is making of the protein. This is normal. Now, if there is a mutation in growth factor or growth factor receptor or signal transduction molecule or nuclear receptor or cell cycle receptors, so this cell with the information is abnormal, so this cycle will continue. شوف هنا زي كده. And the cells grow into millions زي كده, and this mass will become cancer. Mass will become cancer. Okay, cancer. Now هذا سرطان. Okay. Now this transcription where the mRNA is made into a normal protein, this is a normal thing, normal proteins. But this mRNA is abnormal, this protein is abnormal. Okay. Like for example, we have a COVID vaccine, and this time for you remember we've taken Pfizer vaccine, and this you can read on the Pfizer vaccine, it is mRNA vaccine. Okay. Now this mRNA vaccine was a transcribed product of the virus. Transcribed. It's a transcribed, not translated. Now this particular mRNA is going into a body and making proteins which are going against the coronavirus. Okay, this is the normal thing. This is an infectious process, no problem. But cancer, what has happened? The P53 will take control of it will suppress the tumor by when the DNA is damaged, the P53 becomes active, it'll destroy the cell, okay? And it will not cause the cell to proliferate. It will activate the cell cycle abnormalities. Even hypoxia, this becomes activated. So P53 will become activated, and when there is DNA damage or some abnormality, it will cause the cell cycle arrest, no division. So by that time, the DNA will be repaired by the help of other things, and cell cycle will restart. If there is no repair of the DNA, this abnormal DNA will go into cell cycle, and this can cause development of a cancer. I hope you understand. I'm making the subject very simple. Okay. I told you, maybe, for example, hepatocyte, a liver cell, is supposed to die maybe after 27 days. And okay, all these things will become, it's supposed to die by apoptosis. Okay, apoptosis is a form of cell death, programmed cell death. So this a DNA repair which has to be taken place does not take place. So apoptosis will not take place. So the body cannot cause death of the cell and cannot eliminate the damaged cells. So the damaged cells with abnormal DNA will proliferate, will cause abnormal cells, and the cell will become cancer cell, and this P53 mutation will cause an arrest. They cannot arrest the cell cycle. So the cellular and genetic stability is gone. So P53 is a tumor suppressor gene which causes cellular and genetic susceptibility by repairing the DNA repair and will cause cell cycle arrest. Then after the DNA repair, the cell will restart normally. The apoptosis, it encourages the apoptosis. Apoptosis will also stop if there is a P53 mutation. Shufina, tumor suppressor. Okay. We go furthermore. For example, I'm talking about the breast cancer. Now this is the normal breast lobule. We find the lobules inside. We call this alveoli. There are 15 to 20 lobules over here. You can see over, which makes the milk, and the milk will go through the lactiferous ducts into the ductal area. You can see the alveolar cells which secrete the milk, and the myoepithelial cells which squeeze and push the milk into the lumen. Now you can see these areas making the milk. This is the lobules, and sending it through the lactiferous duct and lactiferous sinus into the nipple. From here, the milk will come. This is normal physiology of glandular tissue, where these ducts, show for the ducts, are the muhim jiddan the duct. So this duct usually becomes cancerous. So what we call this? Infiltrating duct cell carcinoma. Okay. Now this will become larger mass like that, Kabir mass. Okay. If it becomes a normal small one, it becomes an adenoma of the breast, of fibroadenoma. It can be taken out by a surgery. It becomes normal. But if it becomes abnormal, then there will be metastasis. Inshallah, I'll talk to you now. Okay. Now, Shufana, we'll take out this one. Shuf, father. Take out barra. So this is the terminal duct and this is the lobule. شوف هنا lobule هذا lobule صح؟ هذا duct. هذا lobule هذا duct. I take out this barra, the terminal duct, and this is the lobule. So inside here there's epithelium, right? Which secretes the milk, and there is myoepithelial cells which squeeze them, and the milk is produced in the lobules, and these are also lined by epithelial cells, and this milk will go through it like so. This is Usamaesh terminal duct lobular unit. So we call it TDLU. Whole of the pathology of breast lies on the TDLU. Okay. Now, Mamana proliferative breast disorders. If there is a proliferation of the epithelial cells, Shufina, if they become proliferative, they become hyperplastic. Hyperplastic, like you have seen yesterday, Dr. Ahmad might have taught you. So this becomes hyperplastic. So proliferation of epithelial cells, no atypia. The cells are normal, no atypical features. Maslan, the cell is like this, normal cells. Okay. What happens if you become atypical? The cell will become larger and the nucleus will become larger because the nucleus become abnormal. So it's making more cells. So it's not atypical, normal cells. There is a small increase in the risk of breast cancer if there is proliferation of the breast cells or hyperplasia. We call the key types in the book like epithelial hyperplasia or sclerosing adenosis and 3 intraductal papilloma. All these types are actually proliferative breast disorders. They are not cancers, but they can be precancerous. Okay. Now you got to control this by doing some tests like biopsy or fine needle aspiration or a test or X-ray called mammography. Hakada. Inshallah, we'll try to read it. Okay. Now benign. أنت عارف سرطان الحميدة يسمى benign. Some changes carry increased risk for invasive carcinoma. ما معنى invasive أصلا? Okay. Maslan, this is the basement membrane, right? Now this is the cells which are on the basement membrane. They are growing normally, hyperplastic maybe or such thing, but the cells could become abnormal, but basement membrane is intact. If the basement membrane intact, it's not invasive. When the basement membrane breaks, these abnormal cancerous cells will go into the subepithelial tissues, and there's a blood vessel over here, there's a lymphatic over here. It goes inside this one, and it can metastasize. يسمى انتشار خلايا السرطان في المخام الأخرى يعني زي liver, lungs and brain. So this is metastasis. So breakage of the basement membrane where the epithelial cells go down to the subepithelial tissue causing malignancy. So this is the one. Okay. Now that is called invasive carcinoma. So the benign disease is fibrosis, formation of cysts, and apocrine metaplasia. These are all the benign changes the basement membrane is intact and the cells are not abnormal. This called fibrocystic hyperplasia of breast. It is benign, but this will become ductal hyperplasia. Must not have a duct cross section. This is normal. Okay, this is normal. This is normal. This is normal. Okay, with all these things. When it becomes abnormal, like big one, and it becomes hyperplastic, right? Hyperplastic. Lumen decreases like this. The lumen is very small and the cells are larger like that. You summon ductal hyperplasia and here a lot of collagen, the sclerosing adenosis. So this is number one, fibrocystic disease of the breast. Number two, ductal hyperplasia, the cancer developing will increase twofold. And this cells will become very abnormal, large nucleus, hyperchromatic, it's some atypical hyperplasia. This third, the cancer chance is 5-fold increase. Here 2-fold increase. Hala kullu benign diseases which can develop into cancer in future if you don't treat. If you don't treat these patients. Mahim jidda. Okay? It can become invasive cancer. I hope you understand. Fahamdum walala. Okay, the nafsul kalam that Dr. Ahmad taught you, I'm concentrating only on breast now. Okay, now breast cancer, major types, almost 95% are adenocarcinoma. Mamana adeno means gland. Mamana carcinoma, epithelial malignancy. Epithelial malignancy, Usamma carcinoma. So this is a glandular malignancy is adenocarcinoma. So 95% of the breast cancer is glandular malignancy or adenocarcinoma. Arise from where? Either the arise from the terminal duct epithelial cells or the lobule epithelial cells. So it can either arise from this area or this area. Okay, as a whole. Okay. Okay. Now they arise from the epithelial cells of the ducts or the lobules. Okay. You know the ducts. Other duct or the lobule. Okay. At diagnosis, अख्तर min 70% they invaded the basement membrane. At diagnosis clinically, all these things, all the cells have been are cancers. They have already broken the basement membrane. The cells have gone down. Anybody want to ask any question? I stop over here. We have a lot of time still. So the most common carcinoma in women by incidence is breast carcinoma. The second most common cause causing cancer mortality. First is lung in mortality. Second is breast. Risk factors mostly relate to estrogen exposure. If the patient is exposed so much to estrogen, so this female can develop into a malignancy if it is not treated properly. Okay, what are the risk factors? We have the female gender, the age, very important. Usually, older females, older than usually 55 and 60 plus. Early menarche, very early starting of the menses, late menopause, because this period, which is, for example, a normal female starts the puberty at menses at 14 years of age and they end at less than 45, normal. Okay, suppose a female start the menses at 11 years of age and ending at 52. Shuf, ada hina shuf ada kullu estrogen exposure. So early menarche and post late menopause is a risk factor for development of a breast carcinoma. فهمتم? Okay. Now, even obesity, because obese people have a lot of. I believe the atypical hyperplasia, which causes marra, maktub 5 times more risk factor. Shuf, 5 times. Okay, risk factors, atypical hyperplasia. And first degree relative, you should ask the patient, do your mother, your sister, anybody has a cancer in the family history, you'll also risk. So these are kullu risk factors totally come sitta. Female gender, age, obesity, atypical hyperplasia, early menarche, late menopause, first degree relative with breast cancer. Okay, now we are going to show Hada duct carcinoma. I told you the duct zakida, duct or the lobules. Okay, now this duct. Now, if you take a section from this, the section will look shufina zakida. As a shuf al malian, you saw florid hyperplasia with duct carcinoma in situ. The basement membrane is intact, but all the cells juva al duct. Okay, ada hua. Malignant growth of the epithelial cells of the terminal duct lobular unit. Okay, malignant cells. But they fill the lumen. They're limited by the intact basement membrane. Hada mohim jiddan. That's why it's called duct carcinoma in situ. Okay, there's one small called maslan. You remember this is the duct and this is the lobule. Okay, these are the lobules. Huh? So this is a lobular carcinoma in situ is one. In this proliferation of the ducts and lobules together. Shufina, Juva, Zekida. Limited to the basement membrane. Basement membrane is intact, no problem. And there's not a cohesive growth. The E-cadherin, very important point for the examination, Shufina. The E-cadherin adhesion proteins have discohesive growth. This lose their intercellular connections, and the E-cadherin functions become less, and the cells will separate like that instead of being attached. Okay, so become separated. So E-cadherin does not work, and the cells will become discohesive, and they become round cell come together. This is lobular carcinoma in situ, either from Hina, or duct carcinoma in situ from Hina. Okay. Now, the same thing, what will happen, for example, this one, this is a duct and this is the lobules. Huh? Now, what happens, there's a cancer inside, blocking the lumen, and the basement membrane over here will break. Now, the cells will go over here, and they come into the lymphatic or the blood vessel, and they metastasize. Hada hua, invasive ductal carcinoma. Most common is the invasive carcinoma biopsy. You can see here, the slide is full of the duct cells, alakulu blue with formation of stroma. Yes. No, half an hour back here. I know. Why? Because I want that. This is a pen. Yeah, I'll give it to you. No problem. Oh, no problem. Okay. So this is Dr. Ahmad, yesterday's professor. Barakallah fi. So, so this invasive duct carcinoma biopsy is, you can see the ducts, the full of the cells are the shufina blue cells and the stroma shuf pink. Okay, so all these cells have gone into the stroma. Now, if you take the patient most commonly in the outer quadrant, now suppose this is the breast of a female. Okay, now this is the face maslan like here. Now the lateral quadrant, the lateral side of the breast, 50% of the cancer arises from this area. Most commonly in the outer upper quadrant of a breast tissue from this invasive ductal carcinoma arises. Now all these questions do come in the SMLE as well as your Taiwan University. Very, very simple things. And this thing. Now there's one disease and another cancer of the breast, Usama-Ash, Paget's disease of the breast. Okay, Paget's disease of the breast. Now there is, you can see over here, this is the nipple, and this becomes, this area should be like that, right? And this, all this area is erythematous. Can you see this erythematous area? You can see over here this erythematous area. Now erythema at the nipple due to underlying, there is some underlying malignancy over here inside. Okay, some underlying malignancy. We don't know, maybe a tumor or inside there. Okay. Now this way usually occurs in the duct carcinoma inside too. Duct carcinoma inside too. Okay, extended to the nipple. So this patient come to the hospital with a nipple discharge. Okay, they have a bloody nipple discharge, and the cells, we call it Paget's disease. The Paget cells are seen on the biopsy. Now this is an MCQ, very clearly coming in the exams. Paget cells, I try to show it, comes on the biopsy. So this is a palpable mass in around 50%. Now if you little press this nipple area and this erythematous area, maybe you find, if you press it little down, maybe you find some hard nodule inside. In 50%, there's a palpable mass over here, and 50% of the cases are detected even on X-ray. You summarize mammogram. Okay, mammogram. Okay, usually an invasive carcinoma is found if you do a biopsy of that ductal region. Okay, now there are different types of infiltrating duct carcinoma. Okay, or invasive duct carcinoma. नफ्स वाहिद. شوف, infiltrating duct carcinoma वो invasive duct का नफ्स वाहिद. The different histological types are lobular carcinoma, mucinous carcinoma, tubular carcinoma. I'll try to show you some figures. Papillary carcinoma, medullary carcinoma, and inflammatory carcinoma. Now, medullary carcinoma, one of the major favorite area of the examiners in the examination day. These people have a BRCA1 gene carriers. So there will be mutation in this one, mutation in the BRCA1 gene, and they ask in the examination, it's a medullary carcinoma. Okay, we'll go forward. Now, invasive lobular carcinoma is there. Now, I told you invasive ductal carcinoma, this is a duct and this is the lobule. I told you the lobule. So, invasive lobular carcinoma, which infiltrates into the stromal tissue. Now, the cells grow in this pattern. You can see this line, you saw single file. We used to call it Indian file pattern, as a Jaish. And the Shuva Jaish in the line Zekida as a single file pattern. So this is an MCQ coming in the examination. In invasive lobular carcinoma, the E-cadherin protein lose the adhesion protein properties, and the cells cannot stick together in clumps. So they are separated. The Jaish. Normally Zekida. Okay. Now they become straight line, single file pattern. So often this invasive lobular carcinoma is present in both the breast. You summarize, the carcinoma is bilateral with multiple lesions. Okay, لازم نسوي هنا تقدم mammography, or you can do a test called fine needle aspiration cytology. FNAC, try to squeeze some of the cells from the breast tumor and put on a slide and try to see the morphology. The morphology of the cells will show a large cell, a hyperchromatic, a high nuclear cytoplasmic ratio. Sometimes even you can see the metastatic figures over there, and very dark. The irregular nuclear membrane and the cell membrane is very irregular. Okay. This is an inflammatory carcinoma. Inflammatory. Alhamdulillah. شوفينا inflammatory. رقم 6. So sorry, this is the one, mucinous. You can see the mucinous pools over here. In the mucinous pools, you can see the cells, abdominal cells. This is inflammatory, and this is mucinous. mucinous carcinoma of the breast. شوف إذا زي you know what you call that swimming pool, misbah. In the misbah, you can see this all the cells are swimming. Okay, there's a mucinous pool in which the cancer cells are seen. This is inflammatory carcinoma. So you can see the mucinous carcinoma over here, inflammatory over here. Okay. Now we are trying to link the genetic properties in the breast cancer, right? So linked to mutations. I told you what to mean by mutation in the change in the nucleotide sequence. It's called mutation. It can occur in the tumor suppressor genes or the proto-oncogenes. So tumor suppressor genes are BRCA1 and BRCA2 and P53. I taught you. And when these cells, when these genes become mutated, the cell division will be affected, and slow cell division makes cells die if they die uncontrollably. Now, if this becomes mutated, so these tumor suppressor genes P53 and BRCA1 and 2, they will cause the cells to die because their function is finished. But if the mutations are there, the cells will not die. It will continue and become abnormal. For example, there's one more cell, one more gene called HER2 new, very important for the examination. Okay, now this is called a human epidermal growth factor receptor. I told you the growth factors, growth factor receptor, signal transduction, nuclear receptor, and the cell cycle receptors. Now, this is a growth factor receptor, this one. Okay, so this is called HER2 new. When activated, promotes growth of cells. So when this becomes activated, it promotes growth of cells. So we have the tumor suppressor gene in the form of BRCA1, BRCA2, P53, and ERB2, which some are HER2 new. HER2 new. In familial breast cancer, cause about 10% of the breast cancers. Okay, BRCA1, BRCA2 gene mutations do occur. Both gene mutations associated with the breast cancer can cause 85% of the single gene familial cases. So genes code for DNA repair. Now these BRCA1, BRCA2, they are supposed to repair the DNA. So these become non-functional or mutated. They will not repair the DNA. The DNA which is being, transformed from the mRNA to the translated protein is abnormal DNA, and that particular thing will become the transcription and the translation. What I call it, gene expression will become abnormal, and abnormal proteins are formed, and that particular area will form a large mass, some breast cancer. Okay. Now, associated with other malignancies like BRCA1 and BRCA2, BRCA1 is also seen ovarian cancer. BRCA2, very important MCQ in the examination, is a BRCA2, male breast cancer and pancreatic cancer. Mohim Jiddan. Mohim Jiddan. Okay. Now, predictive markers, important markers for breast cancer, for prognosis and therapy. You have to show the prognosis as well as therapy. One is estrogen receptor, other is progesterone receptor, another is a HER2 new. That is a HER2 new, or I just told you other name, sorry. Okay, other name was this one, ERB2 or HER2 new nafsu. They have a tyrosine kinase receptor. Very, very important. Because I told you about this one, the growth factor receptor. This will go and touch the signal transduction molecule. Here, the signal transduction molecule is the tyrosine kinase receptor. Tyrosine kinase receptor. Okay. Now, this become abnormal, all this one. So, if ER is positive and PR is positive, estrogen receptor and progesterone receptor positive, that the patient will respond to a drug called tamoxifen. Mohim Jiddan, write it. Very, very important. If the patient is positive for mutation HER2 new tumor, the patient will respond to a monoclonal antibody, Usama trastuzumab. Trastuzumab. Very, very important treatment. Okay. If all the ER is negative, PR is negative, HER2 is negative, it's a very highly aggressive tumor, more common under the 40 years of female, and it is seen in the African American woman highest. So these are all the MCQs coming in your examinations. Okay. For triple negative, I told you, ER is negative, PR is negative, HER2 is negative. The patient is a pro prognosis, seen in African woman, very, very important. Okay. Now, HER2 positivity in breast cancer. HER2 new oncogene becomes abnormal, mutated receptors of the cell surface are seen. So this particular HER2 new is overexpressed. Or sometimes this amplification of the HER2 new oncogene copies in the nucleus. You can see HER2 is normal over here, and you can see HER2 is very much normal over here. HER2 mRNA, the mRNA which is produced, and this mRNA will go. This mRNA is a transcribed product. It will go and activate to make a translation protein. Okay, so you can see over here the receptors are normal, less. When the HER2 new positive breast cancer cell, so this will become 1 to 2 million receptors. شوف هذا بس قليل جدا, but it will become millions of receptors. Now this millions of receptors will make a rapid proliferation which is unregulated, not able to control that one, and it will become a mass. As a mass, you summa cancer breast. Okay, now you got to remember the monoclonal antibody which is being nowadays sold in the market, where the HER2 new oncogene is positive, is the monoclonal trastuzumab is the targeted therapy. You can see it's a normal cell. HER2 receptor is normal. Normal amount of HER2 new cells grow and divide normally in a breast. But if HER2 plus cancer cell, HER2 receptors become abnormal, too much of HER2 is seen over here, like that, like that, like that. So this will become a mass. And if you give this patient a monoclonal antibody Usamma trastuzumab, this patient will become, there's a treatment for it. So trastuzumab has been currently been approved by the breast cancer cases. When the cancer has been detected at an early stage, the drug can be administered both locally advanced and metastatic diseases. Okay, if the treatment for HER2 receptor is positive, metastatic breast cancer as an odd of the chemotherapy, all these cases you can give trastuzumab that will be very useful for even metastasis, as well as the patient who is HER2 new positive. Give this and try to see this cell will become normally like that. Okay, ma mana staging. Ma fark bainal grading of a tumor or a cancer and staging. Okay, al-muhim jiddan. Grading means aggressiveness of the tumor. Aggressiveness. It is done under the microscope by a pathologist. It indicates the differentiation. Is it well differentiated or moderately differentiated or poorly differentiated? It's called grading. What do you mean by staging? Staging is the tumor load on the body. Tumor load on the body. Tumor load. Okay. Zay maslana, stage 0. Very small inside the glands. Okay. Tumor size is very small. Lymph node, there is no cancer. Spreading, confined to the breast area, and the 5-year survival after 5 years, 100% people will survive. Now, when the tumor becomes stage 1, the tumor is less than 2 centimeter. There's no cancer in the lymph nodes. It's confined to the breast area. Okay, not outside. Stage 2. Now the tumor size has increased from 2 to 5 centimeters, affected by cancer in the lymph node. Lymph node juva cancer and mets, confined to the breast area and not outside, localized into the breast area. So 5-year survival in stage 1 is 98%, in stage 2 is 87%. Stage 3, 5 centimeters and larger, affected by cancer. Cancer has reached the muscles in the skin. So this is actually invading into the muscles and skin, confined to the breast area, spreading not outside, still in the breast area, not in the breast area. Now stage 4, Mohim Jiddan, any size, maybe 5 to 10 centimeters, 15 centimeters, affected lymph node is positive for the cancer, and cancer has spread outside the breast area to any part of the body. Mohim Jiddan. So only 20% people survive after 5 years, and 80% will die after 5 years. Mohim Jiddan. From 61 to it becomes 20%. Now, very, very important thing to ask about the risk factors in a breast cancer. So what are the high risk factors? Number 1, if there's a positive family history, if there's a positive personal history, if the female is a Caucasian, there's a white female, more than 50 years. Dense breast tissue. The breast tissue, if you just examine, it's very dense, very heavy breast is there, and that these people can have a risk factor for development of a breast cancer. Okay, usually you can see the dense breast tissue by doing a mammography. Okay, and of course you got to see if there is a BRCA mutation is there or not. If the BRCA mutation is there, please see that this patient is at a high risk of development of breast cancer. Okay, if there's a proliferative disease in ATPI, like you have a duct carcinoma in situ, okay, all florid inside, and this is again a risk factor for development of breast cancer. What about low to moderate? If the patient is nulliparity, did not produce any children, is again at a risk. And the late pregnancy, if the patient started pregnancy at around 30 years of age, is again a risk factor for development of cancer. I've seen hundreds of cases in this particular nulliparity and late pregnancies. Early menarche and late menopause, I told you, exposure to the estrogen for a long time. This is again a low to moderate risk factor for development of cancer. Other slide, Mohim Jiddan Lil Imtihan. And if there is an unopposed estrogen use, like you patient who have obesity or something like that, they use a lot of estrogen, they are also again at risk of breast cancer. History of ovarian cancer, I told you there's an overlap, and history of ovarian cancer can also have a risk factor for breast cancer. Then we have a history of endometrial carcinoma also, where there's a lot of estrogen exposure, also have a high incidence of breast cancer. If the people are taking alcohol, again a low to moderate risk in the development of breast cancer. I think these things are very important. I just copied only very important slides, such that not a single slide is important, very important. Okay, we go to male breast cancer. Okay, male breast cancer, if there is enlargement of breast in male, in male the breast is not enlarged. It is called gynecomastia. Okay. Now the incidence of, so some people can develop male breast cancer from gynecomastia. Incidence is 1% compared to women. 99% occurs in women. Usually in the 60 to 70 years of age. There is a mass subareolar. Suppose there's an areola, there's a nipple, there's a mass over here, somewhere like that, with discharge sometimes from the nipple. Most breast tissues in male are near the nipple. Okay. Key. Now this is an MCQ which comes in the examination. So around 3 to 8% of the Klinefelter syndrome have a male breast cancer. Around 4 to 14% of the BRCA2 gene mutation will have a male breast cancer. Mohim Jiddan. Okay, thank you for your attention. If there are any questions, I'll take up. We have around 10 minutes more. If there are any questions for the students, I can take up. This is a good revision PowerPoint for you. If you have any doubt anytime, you can ask me now. Very interesting, and one of the most important cancers in Saudi Arabia as well as the whole world. Now, regarding the basics of neoplasia, yesterday Dr. Ahmed has taught you benign or malignant definitions of the different types of malignancies. Okay, all those things. How does it metastasize? Everything is so important. Apart from that, you try to understand what is being changed in this particular thing, where the gene mutations do take place, which causes rapid and uncontrolled, unregulated proliferation of the cells. Any doubts or something like that? Any questions you want to ask? Hello, can you hear me?
Doctor, yes. You talked about Robin's basic pathology. I already have the 8th edition. Is it any good, or should I take the 10th?
You have which edition? Which edition you have?
The 8th one.
No problem.
8th.
You can have it. It's okay. 8th is okay.
Okay,
but now in the Jareer, you have a 10th edition. If you want to buy it, you can buy it. But somebody who has 8th and 9th can have it. And you read that now. Today, go and read the chapter of Robbins from the chapter of breast from the Robbins. And if there is any doubt, if you ask me, inshallah, I'll try to show you. Okay. So you can take my number from the leader, and it is available. You can ask any doubts if you have. I hope that it is not very difficult. I'd finished 10 minutes before, so that if you want to ask any doubts or something, you can have it. Previously, 2 years before, my lecture of this breast cancer was around 70 slides. Now I reduced it to almost half of it because I remove all those difficult areas where you're not supposed to read so much. But I think this is enough for you to understand the Robin pathology, or any lecture on pathology on YouTube. You'll be able to read and listen and understand. Okay.
Okay.
Thank you.
The leader, Jazakumullah khair so much for your sending me the link, everything. Inshallah, I just drop your name. I don't know what's your name. Just write there and just say hi to me, and inshallah I'll have your number. Okay. Jazakumullah khair.
You too, Doctor. Have a good day.
Thank you. All right, thank you. What is the attendance come to lab zyada or less?